Um, let's see. Today I'm going to be sharing a little bit about an exciting project, but before I do that, I'll just reintroduce myself. My name is Dr. Isa Granados, and I'm a second-year postdoctoral research fellow within the Center for Healthcare Delivery Science at Nemours. And I've been fortunate to partner with the Nemours Healthy Weight Clinic medical director, Dr. Lee Fan, and we've been able to do a very um, innovative analysis on obesity medication dispensing disparities in adolescents and young adults at Nemours using a linked electronic health record and pharmacy cohort, which has not been done before. We're looking at the recent GLP-1s, and this project we were able to present it at the obesity conference. Actually won top abstract in pediatric obesity, and it's going to be published next Friday in the Obesity Journal. So we're excited to get it out there next week. But I'm excited to be able to share it with you guys a little bit about the study. So, in just a little bit of background, we know that obesity affects 1 in 5 U.S. adolescents and young adults, and it contributes to early cardiometabolic disease and psychosocial burden. The American Academy of Pediatrics recommends intensive health behavioral lifestyle treatment, which is as the first line of care, and that involves a family-based, multi-component approach that focuses on nutrition, physical activity, and health-related behaviors through counseling and support. And we know that effects are modest, and this is really hard to implement for all patients for them to access this because it's resource intensive. Now, for adolescents that don't achieve adequate weight loss with intensive health behavioral lifestyle treatment or IHBLT alone, pharmacotherapy is now a critical component of care, with approved options including GLP-1 receptors like semaglutide, liraglutide, and tirzepatide, in addition to other obesity medications including phentermine and phentermine topiramate. And we know from randomized control trials that these medications provide clinically meaningful weight loss and cardiometabolic improvements in youth, with the top 3, those GLP-1s, producing the most effects. Now, we know that prescribing for GLP-1 receptor agonists has grown drastically for adolescents. It's increased 300% since 2020. But we know that many families, from our conversations with providers and families, they face many barriers to actually getting the medications, from insurance denials to high out-of-pocket costs and ongoing supply shortages. And while pharmacotherapy is extremely effective to help patients in weight management treatment, those benefits are lost when prescriptions are never picked up at the counter for one reason or another. Now, the existing evidence that we have on prescribing and dispensing trends in obesity medications come from looking at policy plan reviews, claims analysis, which is just dispensing data, and that has been mostly in adults. And then there have been communications from the FDA on supply shortages. Some data sets some analyses look at prescriptions or dispensing, but none of them look at both prescribing and dispensing data. And that's what makes this study so different and important, because prescribing only reflects provider intent, whereas dispensing records really capture post-prescription barriers, non-adherence, denials from insurance, co-payment burden, other barriers to getting the medication. And few studies have linked prescribing and dispensing data for anybody at all, adults, children, for any disease, and none have focused or looked at this specific linked data in obesity medications amongst adolescents and young adults. So that's what we set out to do. The Nemours Biomedical Research informatics team was able to link Nemours electronic health record data to SureScript's dispensing data. This was a very difficult process to do, but they were able to link it. And so I was able to run the analysis and design it. And so This study was a retrospective cohort study with Nemours electronic health record data, and our goal was to describe real-world obesity medication prescribing and dispensing patterns among adolescents and young adults, and then look at what sociodemographic and clinical characteristics are associated with these dispensing trends. So we looked at adolescents and young adults that were age 12 to 20 with an obesity medication prescription from Nemours between the dates of January 1st, 2020 to July 28th, 2025. We looked at those 5 obesity medication drugs that I mentioned earlier, and we excluded patients with diabetes because they might have different insurance approvals or coverage if they have diabetes as well. These were just patients that were seeking obesity medication for weight management treatment. So our primary outcome for this study was whether a patient was ever dispensed a medication or not. So it was a binary outcome. It was yes if the patient had at least one obesity medication prescription from the Nemours EHR that was linked to a pharmacy dispensing record. And then patients were listed as never dispensed if they never had a dispensed record at all. There were several potential exposure variables that made up various demographic and contextual variables that we considered for our analysis. These were all taken from first prescription. Keep in mind this was a limitation. Age might change over the years, health insurances might change, but we had to make the decision to choose the variable at first prescription. So we looked at age, sex, race, and ethnicity, language. We also looked at the Childhood Opportunity Index, which looks at neighborhood conditions. We looked at this within the national percentile, and it captures census tract level conditions across education, health and environment, and then socioeconomic domains that may influence the likelihood of obtaining a dispensed medication or a fill. We looked at health insurance. We looked at prescription drug coverage, which was sort of a binary variable of whether or not a person's insurance plan had a separate prescription plan like Express Scripts. Then we looked at drug name, prescription year, and obesity class as well. And we cannot run all of those variables in our model, so we ran a bivariate analysis to determine which ones to include. And from our bivariate analysis, we were left with these 6 variables on the left. Race and ethnicity, insurance type, prescription insurance, drug category, and year of first prescription were all significantly associated with our outcome, and thus were retained for our multivariable regression. And then for Child Opportunity Index, there was a borderline trend, and we decided it was a p-value of 0.06. And since conceptually we thought that was relevant, so we included it in our model. And so given that our outcome variable was binary for our primary analysis, we used multi-level logistic regression. And a new analytic method that I learned through this with the help of our biostatistician was multi-level regression. And that we decided to use that because most patients in our data set had more than one type of drug prescribed to them. I think the mean was around 1.5 drugs per person. So I didn't want to lose the differences that the dispensing disparities by drug. So we decided to cluster by person so that we could make sure that we accounted for that within person variation. So our primary analysis was a multi-level logistic regression, looking at these exposure variables and their association with our primary outcome. And then we conducted a secondary analysis repeating this model, but we stratified by drug type. So we could look at individual differences, how these exposure variables related to dispensing for each drug. And so starting with our table 1, or our descriptive table with our participant characteristics, our cohort from 2020 to 2025 was of 1,194 adolescents and young adults within the NIMBRE's electronic health record. That many patients received at least one obesity medication prescription, and 56% were dispensed at least one fill, while 43% never were dispensed at all. The mean age at first prescription was 16.8 years old. The cohort was mostly female, 61% female, and by race and ethnicity, 37.8% were non-Hispanic white, 33% were non-Hispanic black, and then approximately 24% were Hispanic. Most patients reported English as their preferred language, and participants' insurance at first prescription, most had private insurance, and then close following, their patients had public insurance. About 4% had mixed, and then about 20% had other insurance, which was mostly made up of self-pay, and that's relevant for later. Let's see. Continuing on, 34% had prescription insurance. And interesting, when you look at the next column to the right, among those that were dispensed, 64% had a documented pharmacy benefit. Patients' child opportunity index was pretty evenly distributed across all of the categories. And remember, that's a socioeconomic variable. And then BMI was approximately BMI percent of the 95th. The average was 141.98. Weight status varied. 9.4% had class 1 obesity, 15% had class 2, and 25% had class 3. Then, as I mentioned earlier, about most patients had more than one medication prescribed to them. So the average was about 1.46. All right. So although we had 1,194 patients, we had 1,744 prescriptions in our analysis, and semaglutide by far comprised over 50% of all prescriptions, followed by liraglutide on the far left with a quarter, phentermine topiramate, and then tirzepatide. Dispensing. This graph shows dispensing, and it varied by drug. It was the highest for phentermine topiramate, for phentermine, with 65% of patients being dispensed, followed by liraglutide with 56%, phentermine topiramate, semaglutide, and then tirzepatide with the lowest dispensing at 27%. And interestingly, our observed dispensing rate actually aligns with other dispensing information we have on the pediatric population. Nationally, about 38 to 56% of prescriptions for pediatric conditions are never filled. And so the fact that ours are in that range suggests that it's consistent with other medications, but we need to keep in mind that Nemours is a unique place, and our Healthy Weight Clinic does a lot to overcome dispensing barriers. They have a lot of processes and resources in place, so this may not be generalizable to most clinics. We looked at dispensing trends over time because FDA approvals varied, new medications came out throughout those 5 years. And you can see at the beginning of 2020, when our cohort began, liraglutide dominated the prescriptions, but they dropped off in 2024, and semaglutide really took off in those later years. And part of that is because liraglutide, for example, is a daily injection, which can be a burden, versus the newer drugs like semaglutide was a once-weekly injection. We also see phentermine in the dark blue increasing pretty steadily over the 5 years, and that's a much more cost-effective drug than the more expensive GLP-1s like semaglutide and tirzepatide. So for our primary analysis, we had done a multi-level logistic regression looking at the relationship between sociodemographic variables and dispensed ever. And so starting at the bottom, we looked at how dispensing varied compared within each drug. And so relative to semaglutide, the odds of ever being dispensed were 2 to 3 times higher for liraglutide, phentermine, and phentermine topiramate, but lower for tirzepatide. Hispanic adolescents and young adults also had lower odds of ever being dispensed an obesity medication compared with non-Hispanic whites. Then when we look at insurance compared to private insurance, public insurance and mixed coverage of insurance showed modestly higher odds, approximately 1.3 to 1.6, and then other or unknown coverage showed the highest odds of ever being dispensed at 3 times the odds. And keep in mind, this was mostly self-pay patients. So those that are paying out of pocket are 3 times more likely than someone with private insurance to actually get dispensed. That makes sense with what we know about access in adults as well. Next, having prescription insurance or RX insurance was associated with over double the odds of ever getting a medication compared to those that don't. And then when we looked at Child Opportunity Index, those that lived in high Child Opportunity Index areas were associated with lower odds of dispensing compared to the reference, which was very high. Now, in this forest plot, I'm visually depicting the odds ratio for our model by when we stratified by drug category. However, I'm only reporting the significant associations because it would be a very large forest plot. And we did find many differences by drugs that do mirror our results from the prior slide. To start off, we found that Hispanic and adolescents and adults also had significantly lower odds for dispensing for phentermine and semaglutide, which is similar to our overall findings. We also found that Black adolescents and young adults had higher odds for tirzepatide compared to non-Hispanic white peers. Public insurance was associated with higher odds of dispensing versus private for those on phentermine. And then for tirzepatide, semaglutide, and phentermine, other or unknown insurance or self-pay showed higher odds of dispensing across multiple drugs, which is what we found in the overall model. And then similar to our prior model, having prescription insurance was consistently associated with higher odds across semaglutide, phentermine, topiramate, phentermine, and liraglutide. And then lastly, Child Opportunity Index was generally not associated with dispensing, but we found a small effect for phentermine, topiramate, where similarly high Child Opportunity Index had lower odds compared to very high. And so what does this all mean? This study overall is one of the first to link this prescribing data to external pharmacy records. And by doing this, this is the first study that can provide a more complete picture of real-world obesity access. And this approach helps us understand not just provider intent, but who's actually using the medication and adherence. One of the most striking findings was that only half of patients who were prescribed an obesity medication obtained at least one fill during the study period, which highlights a gap between prescribing and treatment initiation. We saw that over time, prescribing shifted from liraglutide being more popular to then semaglutide and tirzepatide coming into the picture. And while these medications were less likely to be dispensed compared to lower oral medications like phentermine, they were prescribed a lot more. And likely reasons that their dispensing was lower compared to phentermine was because of supply shortages with semaglutide, stricter insurance coverage with the higher cost GLP-1s, and then the fact that some of the pills are injectable rather than oral pills. We observed significant racial and ethnic disparities in dispensing. Hispanic adolescents and young adults were less likely to receive the medication than non-Hispanic white peers, and this reflects potentially structural barriers to getting the medications, logistical or financial challenges, and then potential differences that we see in other literature regarding cultural perceptions of body weight that might play a role in reducing the perceived need for pharmacologic treatment, or more apprehension in seeking a medication that may require an injection. Insurance type mattered in this analysis. Patients with mixed or public insurance had higher odds of dispensing compared to those with private insurance. We know that lower cost generics like phentermine are easier to dispense, while GLP-1s have stricter coverage requirements. And we saw that those with self-pay had higher odds, which shows that there's still a lot of barriers with insurance, and that's constantly changing, coverage details, etc. One of the most interesting findings to me was that having a pharmacy benefit plan, as documented in the electronic health record, was very associated with getting the medication. However, it doesn't really indicate that they had a better plan because every insurance plan has a pharmacy component. It's more of a reflection of the structure of their health insurance billing and processing plan, and maybe contracting with Express Scripts or another company. So this is something that we definitely want to look into in the future. Having a pharmacy benefit plan might serve as a proxy for some other variable that makes it easier for a patient to get their medication. Lastly, we found that higher child opportunity index quintiles had higher dispensing rates. And this is something we need to look into to see what other socioeconomic factors might be driving these disparities. This study was really just the beginning of the work to be done on this topic. There's many limitations and future directions. We're hoping to submit for a PEDSNet study to look at this analysis across different institutions, to look at state level differences, and to involve stakeholders in the conversation. We're hoping to continue working on this. This was just the beginning.